My name is Dr. Ammara Hughes. I'm a GP and I'm a clinical director of Central Camden Primary Care Network in North London and the director of our overarching federation, Camden Health Evolution. We decided to set up a rectal pathology service in our PCN because during COVID we recognised that there was a huge backlog in terms of the number of patients waiting to be seen in secondary care with ongoing rectal bleeding. In our PCN, looking at our data, we see that over a year, over 1,500 consultations happen in general practice with regards to rectal bleeding. The majority of these do not need a 2-week wait referral, therefore they end up on a waiting list with ongoing symptoms but no solution to their problem. The majority of these patients turn out to have hemorrhoids. When we discussed this with our secondary care colleagues, we recognised that a lot of these patients could be managed within primary care with some training and some supervision with our secondary care colleagues. As a result, we worked in partnership with our local trust, University College Hospital London, and we have trained up a bunch of our physician associates who work across our PCN to use this device here, which is called LumenEye. And what we do is we have an internal referral process between our practices for any patients who have persistent rectal bleeding who are FIT negative, so they have a FIT less than 10. Initially, we started with patients under 50, but we've actually expanded our criteria to include all patients under 60. We've looked into the patient satisfaction. The waiting time is less than 4 weeks from referral to being seen, and the procedure is very well tolerated, and patients feel that it's an incredibly useful service.
Hello, my name is Zain Hussain. I'm a physician associate. So in this community clinic, we see patients who have been initially reviewed by GPs in general practice, and they've had initial investigations including calprotectin and QFIT, which has been negative, and a DRE examination. This has been a terrific clinic and a middle ground between the colorectal surgery referrals and secondary care and primary care. I've really enjoyed doing this clinic, the practicality of it, the reassurance of having a colorectal surgeon on the other side where we can refer to if we're unsure about anything at any point as well, and the terrific outcomes that we've had so far as well, where we've avoided secondary care referrals to allow those appointments to be targeted more at people who might need them a bit more urgently.
Hi, my name is Vidhi Patel. I'm a physician associate working in Central Camden PCN. We've been trained to perform thorough DRE examinations, use the proctoscope, and even use the LumenEye machine, which is a new digital rectoscope device. We receive referrals from general practice after a patient has been seen by their GP. Before each clinic, our admin team set up the device that we have here. They put down a list of the patients that we're going to see on that day, and we're able to navigate this really easily throughout the clinic. So we're able to kind of take videos and photographs and even send reports to the colorectal surgeons if needed. We've had a lot of good patient feedback from this service. In particular, we've had one patient who feels that he keeps going to general practice and there's not a lot of treatment options out there for him. We saw him in the clinic and we were able to inject his hemorrhoids very quickly and efficiently, and he was very happy with this service, and he said it even improved his mental health.
I'm Alex von Roon. I'm a consultant colorectal surgeon at University College Hospitals. I got involved with this project about 18 months ago because I was very excited about transferring some of the skills that we have in secondary care into primary care. And we at UCH were actually approached by the Bloomsbury surgery about whether we would do this collaboration utilising LumenEye to essentially speed up diagnostic and treatment times for patients with benign disease. And I jumped on this immediately because I have had the sense for a long time that patients who do not have bowel cancer diagnoses in my field aren't being served terribly well by the current pathways we have that exist to exclude bowel cancer. So the standard pathway would be that a patient has symptoms such as rectal bleeding, which is often caused by hemorrhoids or other benign conditions. They then are triaged by telephone. They come for a test, usually a flexible sigmoidoscopy, sometimes a colonoscopy. That's negative for cancer. They then get reassured that by the hospital that there isn't a cancer diagnosis and discharged back to primary care. And they end up in the GP surgery saying, but I still have rectal bleeding or itching or pain or lumps coming out my back passage that I really want addressing. How can I get those addressed, those symptoms addressed? And then the GP says, okay, well, we've excluded cancer now. Now we need to refer you on the non-urgent pathway back to the same hospital, and then they can wait many, many weeks, some up to even a year in some places. So it was really an effort to try and serve that population of patients better. We have seen really excellent results with this. So the project essentially allowed me to spend some of my clinic time here in the community at Bloomsbury Surgery, and I've been training up 2 physician's assistants in essentially how to take histories, do examinations, do rectoscopy and proctoscopy with the support and help of and reassurance of the LumenEye device, where we can record with video the findings, so that if there are any queries about the findings, and they can be reviewed by someone like me remotely from secondary or tertiary care. But really it's also a skills transfer of the fairly simple management that we often do for things like hemorrhoids and anal fissures, on how to advise patients well on how to manage those conditions, and also offer simple treatments like injection sclerotherapy of hemorrhoids in the community, so we can make those patients better and also actually take them out of the hospital capacity, thus freeing up capacity for more acute patients, for more cancer patients who may be in need of more specialist care. So we're shortening the treatment time, we're shortening the time to diagnosis. And certainly the feedback we've received from patients in these clinics here in primary care has been that they've been very impressed with how quickly they've got seen and treated. And we in secondary care, of course, need to focus on ring fencing out the limited capacity that we have for patients with higher acuity and more complexity. And so I think this project works very well in terms of actually getting everybody what they need. The LumenEye device has been really instrumental in developing this pathway, because it provides additional reassurance to the physician's assistants by recording by video the rectoscopy and the proctoscopy findings on withdrawal of the scope, such that if they have any queries about abnormalities that they're not sure to categorize, they can then check back with me. I can review them in the cloud if necessary, and give appropriate advice. So if we find something that may be cancerous, we can then expedite that patient straight into secondary care if necessary. Or equally, we are able to reassure and say, no, this is okay, doesn't need to come on an urgent pathway. So it's been a very, very useful adjunct to transferring our clinical skills to primary care, and also making the pathways safer.